Doctora Antini.
Muy buenos días. Bienvenidos al Día Internacional de la Diabetes.
Good morning. Welcome to the International Diabetes Day. I'm Carmen Lantini, Regional Advisor for Diabetes Control and Prevention at PAHO. And I thank you to have accepted our invitation to share this moment with us. This will be hopefully a very interesting event for all. We have simultaneous interpretation into English and into Spanish. In the lower part to the right of your screen, you can click on the little globe and choose your language of choice. If you have any questions, we will address them at the end of the presentation. And I simply want to thank you again for being with us today. I want to welcome Silvana Luciani, head of the NCD unit at PAHO, for a brief welcome word. Thank you very much, Carmen. Good morning, everybody. Welcome at this PAHO webinar to commemorate the World Diabetes Day. I will speak in English, so if you want to choose the interpretation to Spanish, you click on the globe.
Open this webinar to commemorate World Diabetes Day today and to lend my voice of support for this year's theme, which is on education to protect tomorrow. This year, we're calling for an increase in diabetes education for the public as well as for health professionals, so that everyone is more aware of the diabetes problem as a significant public health issue in our region and what effective strategies can be used to prevent and control the disease. We're all too aware that diabetes is a growing public health problem and that worldwide, the number of people with diabetes is projected to quadruple and expected to reach to 500 million people by 2030, calling attention to the urgent need to really scale up interventions such as education, prevention, and control and primary care services. In the Americas alone, 62 million people are living with diabetes, mainly type 2 diabetes. And there's over 280,000 people each year who die from diabetes and related complications arising from poorly controlled diabetes. And with the COVID-19 pandemic, we know that the situation for people living with diabetes has worsened because the risks for COVID are much higher in those living with diabetes, but also because the health services were significantly disrupted, which meant that many people with diabetes lost access to continuous care that they need to optimally manage their condition. So now more than ever, we need to raise awareness and education on diabetes. Last year, we celebrated 100 years since the discovery of insulin, a life-saving medicine for many people with diabetes. But we also know that the reality is many people that require insulin still don't have access to it because of the high cost or the unavailability of this essential drug in their country. Furthermore, many people with diabetes remain undiagnosed. It's a silent disease, sometimes with very unrecognizable signs and symptoms, and also because many people have limited access to primary care services for timely diagnosis. So on this day, to commemorate World Diabetes Day, PAHO is joining all the partners, IDF, World Health Organization, and all of you to draw attention to governments and to major global health actors on the need to really improve diabetes education, improve diagnosis and control, and self-management support for those living with diabetes. And every country must ensure that diabetes care, including diabetes education, is within people's reach and is part of the essential primary care package of services. And this may mean offering care outside of the traditional settings or relying on community health workers to conduct outreach and education. And so we're calling on all levels of the healthcare system, including community health workers, to help assist in improving diabetes education on this day of World Diabetes Day. And for insulin and other diabetes medicines and technologies, we're calling on governments to make them much more affordable and accessible to all those who require it. And in this regard, we want to urge governments to make better use of the PAHO Strategic Fund, which offers high-quality diabetes medications at optimal prices, regardless of the purchase size, because of its pool procurement mechanism. So we urge governments, please use the PAHO Strategic Fund to make insulin and other diabetes technologies much more accessible and available. And our health professionals in the region must ensure that people are educated about the risk factors for type 2 diabetes, namely poor nutrition and overweight, obesity, and physical inactivity, as well as what those signs and symptoms are for both type 1 and type 2 diabetes, so that more information and tools can be accessed to better diagnose and control the disease. So to support all of these actions, last year, the World Health Organization launched the Global Diabetes Compact, and it is intended to unite the global health community to improve diabetes care. And PAHO is really pleased to be a partner and join this global effort to implement the Diabetes Compact in our region and to provide the technical cooperation needed to governments, to civil society groups, to people living with diabetes to help improve diabetes education, as well as prevention and control services. And part of PAHO's commitment in diabetes education is to make all of the data and statistics that we have available to us much more visible, so that everybody is aware of how many people are actually affected by diabetes in terms of the impact on death, but also on morbidity, on costs of care, and the inequities associated with access to care. So in this regard, it gives me great pleasure that in our webinar today, we will launch the new PAHO publication called the Panorama of Diabetes in the Americas, which notes the rise in diabetes prevalence and related risk factors in all countries in the region, as well as documents the capacity and the gaps in services for diabetes prevention and control. So please join us at PAHO in raising awareness and expanding access to diabetes education, diagnosis, and treatment services across all the countries in the Americas region as part of our efforts to build stronger and more resilient health systems in the region. So thank you all for your attention and participation in this webinar today, and let's proceed now with the World Diabetes Day webinar. Over to you, Carmen.
Muchas gracias, Silvana. Realmente una excelente
Thank you
introducción.
very much, Silvana. An excellent introduction for this important day and for this webinar. And I'm very pleased to implement this seminar. As Silvana said, we are pleased to present during this day our first diabetes-specific publication for the region. I will share my screen to start the presentation of the Diabetes Panorama in the Americas. This document presents the most up-to-date data available with an international comparability. So don't be surprised that some countries have different data from the ones we manage, but are essentially comparable at an international scale. Very briefly, we will address the document's structure, its main results, and what is the current PAHO work on diabetes. The document is organized in 8 chapters. The first one is the diabetes burden in the region of the Americas. Mortality by diabetes, premature mortality by NCDs, unconditional probability of dying from NCDs, life years lost, to diabetes, and then dailies, and then the prevalence of diabetes and its risk factors. And here you have the estimates about overweight, obesity, and insufficient physical activity, smoking. And we cannot complete the document without addressing diabetes complications, diabetes and comorbidities, and the national capability of the country to prevent and control this diabetes epidemic. And there's also a brief chapter related to the impact of diabetes on indigenous populations, and as Silvana mentioned, the impact of the lack of availability and access to insulin. Briefly, the main results of the document. We find that in the last 40 years, diabetes increased in its prevalence from 5% to 8.3%. This has been an enormous increase, a relative difference of 66% in prevalence. If we translate this into the number of individuals with diabetes, we see that since 1980, the number of such people increased from 18 million to 62 million people with diabetes, a 244% increase, a trebling of number of people with this condition. Not only the prevalence increase, but the burden. And in just 20 years, diabetes mortality increased by 70%, and dailies, disability adjusted life years, increased in 88%. Twice as many men as women die from this condition due to dailies. Each year, more than 8 million life years by premature death due to diabetes are lost, including kidney disease related to diabetes. This data that are simply referred only to diabetes. But if we consider that diabetes comes hand in hand with other diseases, its burden is really sobering. I mentioned that prevalence had increased by 66%. Here we have a snapshot of the trend of the high prevalence of blood glucose in the region. All these graphs are available in the document, and the data can be downloaded from our NCD department website. And all of these countries have seen an increase in the prevalence. We could think that this is a coincidence, but these countries are have that as a most significant increase. But we see that all countries in the region, or most countries in the region, have an increase in prevalence, not only of prevalence, but of mortality, which I mentioned increased by 70%. But the most striking thing of the situation is that in the last 10 years, the 10 countries that have the leading places in the diabetes mortality rates have remained uniform, with very slight variations for men and women, so practically uniform. Between the years 2000 and 2019, the age standardized rate of life years lost by premature death went from the 10th to from the 6th to the 8th position in just 20 years. And if we concentrate on dailies, disability adjusted life years went from the 6th place in 20 to the 4th place in 2019. We should talk about the complications also. The document is the most up-to-date document in the region. But maybe after the publication, maybe other articles have been published, and but we were unable to include them. What are the main complications? The diabetic retinopathy, chronic kidney disease, and diabetic foot. Diabetic retinopathy is the main cause of blindness, a world prevalence of 2.6%. If we throw a larger look to people with diabetic retinopathy, the prevalence is 34.6%, and the estimates indicate that there would be practically 93 million people in the world with some degree of diabetic retinopathy. In the Americas, in Mexico, 48% of diabetic retinopathy, and the United States of America, 35%. This is very striking and impactful disability, but early interventions can reduce the risk in almost 57%. But not all people have access to an early treatment and assessment. Chronic kidney disease is also a significant complication. It is estimated that between 12 and 55% of individuals living with this condition have chronic kidney disease with high incidence. Diabetic foot is one of the main causes of morbidity and mortality in people with diabetic, and there's an amputation risk 10 to 20 times higher than the population without diabetes. Estimates indicate that in Brazil there would be 58.2% of individuals with diabetes that have diabetic foot complications. In Chile, 30% require amputations. And in Mexico, there's a high increase of hospitalization rates. And in Costa Rica, there's also a significant problem of diabetic foot comorbidity. This is a topic, that is to say, the COVID-19 times increase the risk. Cardiovascular diseases, tuberculosis, and others are the three main comorbidities. Cardiovascular disease, the risk is up to 5 times greater than the population without diabetes. That when it comes to the cardiovascular disease rates, and population studies in the US, Mexico City, and Cuba indicate that the risk of death when an individual has a previous diagnosis of diabetes is higher than the rest of the population to die from cardiovascular diseases. Now, when it comes to tuberculosis, the situation is very challenging, and here diabetes is one of the main 5 risk factors, related to tuberculosis. There's an increasing risk to go to an infection and to a multi-resistant tuberculosis. Tuberculosis also favors the appearance of diabetes and interferes with diabetes treatment given the medications. As world estimates indicate that in 2019, there were 350,000 incident TB cases directly attributable to diabetes. And in the Americas in 2018, we had 4% new cases of TB associated with diabetes in our region. I already mentioned the pandemic. You will remember that the first wave of COVID-19 deaths affected, first of all, people with diabetes who were two times more prone to have serious infection by diabetes. And unfortunately, this risk is independent of other comorbidities, and diabetes is a risk factor for COVID-19, but it's also a disease that worsens when a person contracts SARS-CoV-2 infection. And another consequence is that during the pandemic, there was a severe suspension of health services that took care of people with NCDs, and the survey conducted by the WHO in the second round, 28 of the 54 countries that responded to the second round indicated that there was a significant restriction of services during pandemic as to the national capability to prevent and control diabetes. This is based on the biannual survey of national capabilities, and this covers several aspects related with NCDs that we can indicate that are with national policies and plans for diabetes and NCDs, national guides and protocols, availability of medications, and surveillance and monitoring. The most relevant thing is that in 2021, 35 countries responded to the survey, and only 32 countries had available insulin in at least 50% of public pharmacies.
That is what Silvana emphasized at the beginning of the seminar, which means that the people who need insulin to live did not have it available. And as to basic technologies for diabetes, only 12 countries responded in 2021 that they had the 6 basic technologies to have adequate control.
Revisar el documento, ¿qué es lo que podríamos
After
nosotros?
reviewing the document, what conclusions can we draw? First, diabetes is a highly preventable and controllable disease, but it's very debilitating, but it is preventable and we can achieve that. How can we do that? We need to strengthen diabetes prevention, the risk factors, screening for diabetes in the general population. We must detect it way before complications occur, and we have to teach the population at risk and follow them very closely. We need to increase our diagnostic capacity for diabetes everywhere and get people to come. We have to have continuous monitoring of people who live with diabetes, and we need to strengthen the capacity for care at the secondary level. This means it goes in hand with diagnosis capacity and the capacity to have early detection for any complications caused by diabetes. Access to quality diabetes education must be strengthened in all countries. We need to guarantee that both the healthcare teams and people who live with diabetes, their closest circles, their caregivers are well trained. We also need to guarantee access to medication and essential technology for diabetes. This includes particularly insulin. Information systems for compilation and monitoring data are vital. We cannot do any adequate planning in healthcare or implement successful interventions to slow down diabetes if we don't know exactly what the magnitude of the problem is. And during these times of pandemic, it's imperative to find and incorporate digital solutions that are evidence-based to help people who live with diabetes. Telemedicine, educational apps for monitoring are fundamental. But we shouldn't forget that diabetes also needs to be included when planning and providing health emergency care. Remember that unfortunately most of the countries were not prepared for the pandemic, but they also were not prepared to continue the care for diabetes during the pandemic and after it. The impact of diabetes in the population is huge. And as Silvana said, that's what led us to launch last year the World agreement against diabetes, because it's an agreement, a covenant that agrees to build resilient health systems that can provide quality care that is equitable and accessible to everyone, but also involves that persons who live with diabetes are part of the planning. It aspires to have participation from civil society as well as a society that is directly affected by diabetes. This year, at the very beginning of this year, new goals were set for controlling diabetes that need to be completed by 2030. These are much more demanding goals than we had before. But if we don't set high goals and demanding goals for ourselves, we're not going to be able to succeed. We expect that by 2030, 80% of persons who live with diabetes should have been diagnosed, and 80% would have adequate control of their blood sugar. 80% of the persons with diabetes that has been diagnosed have good control of their blood pressure, that 60% of persons of 40 or more who have diabetes receive the statins to prevent disease, and that 100% of the people with diabetes, one, have access to insulin that's accessible and to be able to check their blood sugar. Some of the resources we have available in PAHO are downloadable on our page. Here are the images, and you can look at them later on. And I think it's a good page to visit today. This is the link to my presentation and what I wanted to share with you today. After giving you this fairly quick overview of the new document on diabetes, we'd also like to share with you country experiences that can serve as an incentive for other countries. And it's always interesting to see how others have been successful. I'd like to invite Dr. Nubia Bautista, the director of the Department of Non-Communicable Diseases and Health and Social Protection in Colombia, to give us her presentation. Good morning, and thank you very much. Thank you, Dr. Carmen. Thank you, Dr. Luciani, and our colleagues who are with us from Chile, Dr. Camila Lara, and the delegates participating. It is an honor for Colombia and a great opportunity to talk about some of the actions we have taken in our region to improve diabetes management. And so I'd like to share those with you. I will share my screen.
Quisiera saber si se ve adecuadamente.
Can you see the screen? Yes, perfectly. Thank you. Well, the first is warm greeting to Apajo and to Galina Corcho for giving us this opportunity to have a dialogue, to share experiences from different perspectives, and to talk about different possibilities and have the best learning examples for a disease that is growing in the region. Briefly, I'd like to mention that the status, the situation of diabetes in Colombia and the factors that affect this situation are it require policies for control of diabetes, and something that we feel is very fundamental and promising, and it could be one of our major challenges, is the social participation of the citizenry through a specific mechanism we have developed called a roundtable for citizen participation. As to the situation in Colombia, as Dr. Carmen mentioned, in our country, we have different sources of information. One covers people who have had a diabetes diagnosis, and there we find a prevalence rate of 3 0.11 per 100,000 inhabitants. That amounts to about a bit more than 1,474,000 persons, of which almost 60% are women. And the greater prevalence is where there is a greater population density. Bogota, the capital, Antioquia, and Valle, that have a large part of the population. As you can see, our mortality rate dropped slightly in 2020, but you have to keep in mind that that was the year the pandemic was occurring, and the data is affected by the pandemic, and it affected people with chronic diseases, non-communicable diseases, particularly those who had diabetes, and it led to significant disability. It's actually the 7th reason for daily in our country. Here you can see the local picture, panorama. Diabetes is the 5th cause for premature death, those between 30 to 70 years of age. And we see greater mortality in the territories where there's greater sedentary behavior, smoking, and obesity. We also find great mortality in those territories that have lower access to diagnostic techniques and to new treatment technologies. We have low access to insulin in some of the more peripheric outlying areas of the country. These are the indicators of the access that people have to coverage at clinics and results. For instance, we see that a bit more than 53%, excuse me, have LDL, and of that percent, almost half show proper control. We also have more than half the people have adequate control of their LDL control and the measurement of creatinine in the latest year. That amount, those are about 70% almost. As to body weight, mass, only 25% have checked their body mass weight. What is the comparison of Colombia to other countries in the region? We find that we're about midway down. We have been able to reduce mortality. It is the 5th for the last few years, and this has to do with the demographic transition of our country. It's aging, and the older population and the morbidity has increased because of COVID, and it had an impact on weakening the population, particularly in reducing physical activity. There's been a significant number of children, for instance, who have shown increase in weight, and they also have a lot of sedentary behavior because of it. 82% of the children spend more than 60 minutes in front of an electronic device. 40% of the children have increased weight. We have other factors that affect non-communicable diseases. I would like to highlight here the blood sugar in blood, to which we can attribute 63,000 deaths in our country. What have been the policies we have developed in Colombia? There is a significant milestone, which is universal health care that began in 1990 and has been gradually increasing, and almost 99% of the population is now covered. But that presents challenges, which means that the coverage is not equal in all regions, and there's some areas where more outlying areas of the country where coverage is low, and the arrival of Venezuelan migrants has put a heavy burden on the healthcare system. After 2000, we began taking program actions to detect early cardiovascular risk for persons over 45 years. In 2013, we developed a public policy in the country called the 10-year plan that had a specific purpose to prevent and control not non-communicable diseases, particularly the management of diabetes, and adequate results in health had specific goals. Then we developed a follow-up of cohorts of risk. It's called the high cost account. And then in 2015, Colombia began as a pilot project implementing the HEARTS program. In 2018, we had a developed a policy on health that was developed, and we developed what we called a road to promote and maintain your health. And we did screening for the for risk of those who are over 18. But as you see, we still have very little coverage, only 10.4%. And then in 2019, we developed a specific roadmap for risk and developed a citizens roundtable to link people and families and communities to the public policies and have direct impact. That roundtable was created because of the request of the various organizations that are not just user, but they're also social entities. So it's a very interesting space where we have interaction between the communities and the professionals who do prevention and control and management of complications. Currently, the country wants to create a much preventive model, much more targeting primary care. And we think that this is feasible to help us achieve the goal that care be focused on the person, that it be sustainable and to preventable, much closer to the actual lives of people. I now would like to speak about the protagonists of this roundtable because they have enriched our policy. It has become a space not only for discussion and consensus, but for new initiatives about the treatment of diabetes, and have participated significantly in the developing a preventive model. I would like to give them the floor through a video. If you could help me share this video, please.
Minutito, por favor.
Give me a minute, please.
Mi nombre es Erika Montañez, directora.
My name is Erika Montañez, director of the Foundation of Diabetes Voices in Colombia, and proponent and a member of the Non-Communicable Disease Roundtable Colombia. These diseases in Colombia is a real exercise that shows how you can empower leaders who work on behalf of these conditions in the country. It's a space that was created as a request of the population because of a specific need at that time. That is, we needed to actualize the clinical diabetes practices and have an impact on the public policies that have an impact on cardiovascular diseases, diabetes, and other chronic diseases. This space has allowed us as leaders to participate closely in the consultation process, improving the maintenance routes and the healthcare programs for these diseases. Even though over the years we have not yet updated the practical clinical guide, we do think we can achieve it. And we have done some very collaborative work and trust with the technical team of the Ministry of Health and Social Protection. However, what I would like to request is that social participation be considered not as a duty of the institution, but as a duty to meet the collective rights and to protect those rights, which is the main reason why we exist and you exist as an institution. And that commitment that requires social participation requires urgent attention, must be much more rigorous, much better measurement indicators so that we can real results in the communities. My name is Jorge Garcia, I'm director of the Foundation Retorno Vital, and I am part of the roundtable on non-clinical diseases. For us, this is a point of confluence for many of the stakeholders in the health system. But what's most important is that civil society and the organized civil society that I represent have been able to propose projects that are sustainable and provide sufficiently strong data to develop public policies. We're very proud to belong to this roundtable that is so needed in our country and our system in Colombia. For us, as Colombian Association of Endocrinology and Diabetes, it's very important to participate with the Ministry of Health in these roundtables because we can have an impact on promoting, preventing, and developing and preventing diseases in our country, such as diabetes, obesity, and high blood pressure. As a representative of D-Food International, it's very important to participate in this roundtable because at the global level, we are committed to the promotion and prevention of and care of the diabetic foot by creating an awareness, education, and research. But to bring about change in public health, you need the support and commitment of the government. That's why these sheets on a diabetic foot are only the first step in Colombia. We have to continue working to put an end to amputations that can be avoided. The roundtable means for me an opportunity to work in one of the goals that is the promotion and early detection of a risk in those patients who have diabetes and to contribute to decreasing amputations in Colombia. One of the goals of the vascular table main goal is to provide primary health care doctors the necessary tools to have early detection of diseases, vascular diseases in diabetic patients who are complicated and non-complicated. Second, give the patients, the patients with diabetes, the means of detecting the symptoms early on so as to avoid amputation of their lower limbs. And finally, and no less important, to continue with the different organizations of patients, scientific organizations, and the government, working with them to continue managing and controlling diabetes.
Bueno, ellos son algunos de los representantes de nuestra mesa.
These
Realmente
were some of the members of our table with a great focus in public policies and the definition of instruments. And this has been the focus on education for the families of people with diabetes, the people with diabetes themselves, and health ministries. And so we are very proud. We believe that absolutely education to protect tomorrow is a reality, it's a possibility, and we can continue working collectively in that direction. Thank you very much. Thank you very much, Dr. Bautista. It's really a very interesting initiative, and that is aligned to the Global Diabetes Compact. Let's learn about another experience, and now invite then Carolina Lara. She works at the primary care division in the health ministry in Chile. She will address the experience implemented in her country for an early detection of diabetic retinopathy. Good morning, good afternoon, everybody. I will share my screen. First of all, I want to thank the organization for the invitation to be here today to share my experience that we have been developing for quite some years now, given the growing need and the limited resources around the world. And so we need to use experiences from other places to respond better to our own situations. The context briefly: diabetes in Chile. In Chile, there are Chile has about 20 million inhabitants. Most of them, 70%, are taken care of through the public care network. 9% in 2010, and now we are at 9.4% or 12.3% in 2017. This is the prevalence of diabetes. The projections are not very encouraging because as in the rest of the world, we expect that this will increase exponentially given the high percentage of individuals that are overweight, obese, or have a sedentary lifestyle. And the most terrible thing is that not only the number of people with diabetes increases, but also the disability adjusted life years also increases. And this has several complications such as kidney disease, stroke, IAM, retinopathy, and others. Retinopathy is one of the leading causes of blindness in the active population. This happens when the chronic hyperglycemia levels generate a microangiopathy at the retinal level. Between 15 and 20% of people with diabetes have some degree of retinopathy, and the prevalence of DR in people with diabetes is between 20 and 30%, and 5% are at high risk of losing their sight. The prevalence of diabetic retinopathy is related with the timely diagnosis of diabetes. In countries where there's no possibility of early diagnosis and detection, this prevalence will increase. In Chile, both diabetes and retinopathy are part of the explicit health guarantees. So there's a guarantee of timely and early diagnosis. How is diabetic retinopathy diagnosed? It's done through an exam of the ocular fundus. It has to be done once a year or even more frequently when there are already retinopathy signs or when the person does not take good care of its diabetes. It's a largely asymptomatic disease until there is visual loss. And the purpose of the oculus fundus exam is to have an early assessment to diagnose and treatment and prevent the loss of visual sight, and the prevention of risk is 12 to 28%. So that is, we have a problem, we know how to diagnose it and how to treat it, but something is happening, something's going on. And actually the largest problem is that we have a growing population with diabetes, and we have a lack of annual ophthalmology consultation hours in the public health network in the country that takes care of most of the population. But even if we had enough eye specialists, we have also a cost effectiveness issue. So the solution, given the idea of a Chilean engineer that participated in this project and presented it in an open competition, and this is supported by several municipalities, labs, and the health ministry in our country. It has been already piloted It's being supported by the health ministry, it's being validated, and then it's implemented, and it was implemented in 2018. And since then, the project is already in development, no more under planning. It's already a strategy, and it's being implemented in the digital health department of the health ministry. This strategy includes telemedicine, ophthalmic medicine with screening, and based on the screening, it will go to a remote medical report. How does this work? First of all, the cardiovascular health team of the primary health facility refers ideally all patients with diabetes to the annual oculus fundus assessment. And if their network does not have a UA, LPO, or a primary ophthalmic care unit, if there's no such capability, this is referred to a more complex hospital with an ophthalmic medical technologist for an in-person assessment. And if the patient turns out not to have retinopathy, the person will be advised to continue caring for diabetes. If retinopathy is diagnosed, it will be referred to treatment. And this is a requirement for the functioning of this strategy. There is a primary ophthalmic care unit. In that case, the patient is sent to conduct at that unit the retinography. Then the doctor uploads the images to the platform, and once the images are processed are then treated by artificial intelligence. If retinopathy is discarded, the person continues its regular or her regular treatment and controls. But if the artificial intelligence platform suspects that there are signs of retinopathy, these images are referred to the remote assessment by a specialist hired by the digital health department or by the health services, and thus the professional analyzes remotely the images, issues their report, and invites the person to continue its treatment. If the certain images don't show any retinopathy, the person continues with the regular control program. But if the professional determines that there is retinopathy but non-proliferative, the care is routine. But if there's a severe criteria, such as an ocular edema, the patient is referred to a hospital for an in-person assessment by a specialist. That's the flow. Requirements, first of all, primary health care has to impress on the person the importance of an annual exam, and we need a platform that makes it possible to transfer and store images. We need AI software, and we need a specialist, and we need a coordination within the network between primary care, primary ophthalmic care unit, and hospitals. We need to refer cases at 3 levels, from the higher to the lower complexity, because a patient with a bad control of his or her diabetes will be at higher risk. So when low or non-proliferative diabetic retinopathy is detected, the patient is referred to control. But we need strategies implemented to provide the treatment required by retinopathy, such as laser, for example, because without these capabilities, the message makes no sense. And all this process makes no sense if it's not complete. What were the results of using this strategy? We realized that we could screen and filter out about half of the people that were examined. And it was also possible to improve the times a person that goes to an oculus fundus exam, the processing through artificial intelligence is ready in 48 hours or less, remotely up to 5 days. And if there's a detection of that requires an urgent assessment, things are done for this to happen. So before the strategy, people had to wait 2 to 3 years. Now this has changed, and we are talking of simply a few weeks or days and not years now. And the strategy has been validated. It showed to be very sensitive and specific, and it was a cost-effective procedure because most of the people assessed stayed at primary controls without the need to be examined by an eye specialist, which decompressed the pressure on the health system. Here we can see the screening results and the medical assessment. After screening, 51.25% of exams were filtered out, and the remaining 49% that went to a medical assessment, about 30% were considered as without any suspected retinopathy. And about the other 20% had a slight non-proliferative diabetic retinopathy, moderate retinopathy, severe and proliferative. And this in the aggregate is 2.5%. If we extrapolate this to the 1,800,000 people with diabetes that needed screening, this would be different if we can screen them and filter out those that don't need it. So there's a reduced pressure on the hospitals. We had great ambition at the beginning. From 2018 to 2019, the increase was remarkable, but then unfortunately came the pandemic, and the coverage of oculus fundus exams in diabetic people with diabetes fell. But here we see how the strategy bolsters the oculus fundus strategy exam, because we see a direct effect. So our tool and the strategy is a cost-effective tool, and it frees up hours of eye specialists so that the treatment of diabetic retinopathy can be swifter, because before there were few opportunities and long waiting times, and now the strategy has improved the performance of the entire system. This is what I wanted to share with you. Thank you, Carolina. Thank you very, very much. Really an innovative initiative that, just as the initiative showed to us by Dr. Bautista, goes in line with the Global Diabetes Compact, which calls for the implementation of technology to give an adequate response for our problems. Our motto today, this year, is education to protect tomorrow. And now I want to invite Dr. Ana Fernandez Sanchez, in charge of the Education Working Group of the IDF, to address education on diabetes. Ana Fernanda, it's a pleasure to have you here with us today. Good afternoon, everybody. It's a pleasure to be here with you, sharing this very important space. Thank you very much to PAHO for the invitation. On behalf of IDF, I'm very happy to share this space and share a document that came out of the work of a multidisciplinary working group at the regional level. I will share my screen.
Se ve perfecto, pero se adelantó.
We can see you perfectly, but you jumped one slide ahead.
Bueno, como bien me había presentado Carmen, soy Ana
As
Fernanda.
Carmen said, my name is Ana Fernanda Sanchez. I'm the Director of Education in IDF Saca region, and under my guidance, we worked on the clinical practical guide for clinical education in diabetes in Latin America. It's important that you be familiar with the process that led to this document, because the idea and the interest of all of us who are members of IDF is to begin implementing this in each one of our spaces. And this is an excellent opportunity, since we have professionals, healthcare professionals from all countries in the region listening. And it's important that you know how this document was prepared and become familiar with it. We work on the GRADE platform. It's one of the best known for developing clinical practice guides. So we use the platform to draft the document, but we had some other platforms that were directly involved in order to meet all the processes required by a practical guide. So we had the Agri2 system. We used the REDCap system for follow-up and monitoring of the guide, Sotero, which was the compiler of the bibliography, and other platforms that help to support the development of this guide. The guide meets all the stages required for it to become a document that can be used by governments, organizations, and societies. And we laid out the outline of the scope and objectives. We developed a drafting group, included 20 people, a multidisciplinary team of professionals, because we feel that education should be taught by a multidisciplinary team. We also developed more than 25 key questions, but we ended up with only 10, which I will show you later on. We researched more than 1,000 bibliographies summarized in 245. We did an evaluation summary of literature to prepare the recommendations. We also had the involvement of several external revisers, not only in Latin America, but in Europe. And finally, we have a plan for the implementation of the guide, so that it's not left on the desk only, but that it is actually implemented in the field for the benefit of the patients. And of course, the editing and printing of the document. Important points: 10 recommendations evidence-based, 152 pages long, and 245 bibliographical references. You will find those in the full document. We could never ignore those who are directly going to benefit from this, and the reason why we prepared the document, which are the patients. So the guide does have a space devoted to the patients, and they, through their own creativity, in this case through drawings, expressed what diabetes means to them. And so this is a space devoted to the people for whom we work. when you look at the guide, you're going to find the recommendations as follows. It has three parts to it. The methodological part, which in the document appears in the document. Then it has a section with 10 questions with the recommendations and justifications for why one situation is preferred over another. And then it has a second phase where we include the articles of the fathers of education, for instance, Dr. Jafri Rasal, Peter Gersfeld, amongst the most distinguished figures who have worked for years on education for diabetes, and from whom we inherited this interest to generate this knowledge and spread it to the community. So here is an example of the questions that appear. As I said earlier, it's important to look at each one of the questions. And so I'm going to take some time to create interest and involvement on your part. So the first question is, what model of care should be used for an educational program in order to train and improve the behavior, self-care behavior of people with diabetes? We have used the chronic care model of the WHO because we feel it's one of the most important, where the patient and the professional work together to improve results and the quality of life of the individual. We can't do isolated work where the patient is following one course and the professional a different one. But in order to achieve this synergy, we have to have a healthcare professional who's fully trained, and we need to have support in making decisions from the authorities. We also have to have a proper technology and information systems that allow us to get to know the patient, and so that there can be a joint review of how the disease is being managed with a person. That's why in the guide, we encourage this chronic care model in order to improve and have better outcomes. Question number 2 says, what are the key issues that a healthcare team needs to address when talking to a person with diabetes in order to improve their metabolic management and prevent or decrease any complications? I think we are all aware of the fact of what we need to talk about in each one of the spaces, where we have to motivate a patient to properly follow and comply with a treatment. But we also must keep in mind that this must be done in order, and we should not eliminate any one of the spaces. That's why it's suggested that we first talk about healthy food, physical activity, self-monitoring, therapeutic compliance, resolution of daily problems, uh, having a positive attitude, and risk reduction. In other words, we need to educate our patient in a comprehensive manner, from a comprehensive approach. Question 3 says, what variables should be taken into account when the first assessment of a person with diabetes is done in order to determine their educational priorities? I think this is a very important question that is often not taken into account when meeting with the patient. And unfortunately, because there's a lack of time, we have very little time with our patients in the healthcare system, maybe 15 or 20 minutes only, or in private spaces, maybe 45 minutes to an hour. And if you give too much content to a patient at once, they don't assimilate it correctly and properly. But we need to provide this information and taking into account the realities, for instance, the emotional situation, the self-care skills we need to teach. We also need to understand the cognitive abilities of our patient. What is his level of literacy? Does he or does he not have family support? These are all good practices, and you'll find many more details about these in the guide. But it's also important to keep in mind that we should not forget the history, the background of the patient. We have to keep in mind that in front of us, we have a person who has a certain lifestyle, certain characteristics, a series of life circumstances that are now part and parcel of that person, and we cannot change overnight. We also must find out whether the patient has any other kinds of comorbidities or has any other kind of complications. In question number 4, we talk about the pedagogical methodology that should be used in the educational program so that a person with a diabetes is more compliant with treatment from drug treatment and makes therapeutic changes to their lifestyle. In the bibliographic review, the most important thing was to have a behavioral program that leads to changing behavior and so that the person can adhere properly to the treatment. Question number 5 says, is virtual or distance education equally effective compared to in-person education in order to promote empowerment for self-care of persons with diabetes? I think we're always going to find, and through life experience, we're going to find that in-person education is the most important. But after the pandemic, we've learned that we also should use technology to reach each and every one of the persons in an adequate manner. We have to take into account their mobility, their availability to go to a healthcare center. And so in this case, it would be very important to use technology. Also, technology has allowed us to join the rest of the world through networks, and that's why we see so many people from different countries gathered here this morning so that we can take back knowledge and be able to support our patients. Question 6, how should the transition of persons living with diabetes from pediatric age to adult age? And we considered this question because in Latin America, very often we fail in this transition process from childhood to adult. We often consider that the endocrinologist can support the patient up until 18, in other spaces only to 16, but we not think about how the patient feels about this. That's why it's very important to present and schedule and program the transition, do it adequately so that the patient becomes the main actor of the process and tells us how he feels, how he would like to transition, how it's going to fit in work with the new professional, particularly when you're dealing with people who have diabetes type 1. Question 7 is one of the longest because we talk about the importance of technology for diabetes education. As you know, a diabetes educator must be fully trained and constantly updating their education. We have topics such as self-monitoring of glucose, and we also have the continuous monitors that are very fashionable and are available in many countries in Latin America. Unfortunately, in Ecuador, we still don't have this. Many of the people who use it bring it from abroad. We also have who should know about the use of syringes and pens. What is the appropriate technique so that the patient puts in the correct dose of insulin? We also have to talk about insulin pumps and their importance in using them, because in many cases when a person has certain resources and they have a diabetes diagnosis, they think that by just buying technology or having technology, they're going to live perfectly well. But technology without education is useless. So the technology in the area of digital health, such as in this case, telemedicine, electronic data, etc., are all very important. And also the apps that exist, because now there's a lot of apps that, and we as educators or people that teach about diabetes should know how to use them so that we can recommend the most appropriate for each patient. In question 8, we talk about the psychological impact that diabetes has, its treatment, and how you detect that psychological impact. This is a very important area because we have to begin adequate care of mental health for people with diabetes. So we ask that there be a support provided, that be support provided from the very moment of diagnosis in the hospital areas, in the healthcare centers, so that the person doesn't leave with an unstable emotional situation, all upset, which then creates a lot of problems for compliance with treatment today, or even abandoning treatment, because sometimes emotions play such a strong role. We feel so well and comfortable with the good treatment given to us by a doctor or the good doses of insulin or a drug that we decide to stop taking it. And that needs to be therefore addressed by a psychological specialist, so that compliance is done step by step, and we can include the patient. The patient can include the treatment and as part of his daily life routine. Question number 9 talks about recreational educational camps, an effective strategy for increasing empowerment and self-care for people with diabetes. The recommendations we found uh, target youth and children's camps, but keep in mind that we can also create spaces for different age groups according that we lost her sound.
De nuestras personas con diabetes que tenemos a
According
nuestro
to the
alrededor,
characteristics of the patients with diabetes who are around us. Question number 10 says, what is the best evidence-based approach to bring about behavioral changes in people who have diabetes? And as we said earlier, it's a behavioral model has to also take into account the transtheoretic model of change. This will help professionals understand whether their patient has gone through each one of these stages, which we, the psychologists, call grief, and get the patient to begin expressing and reaffirming and sharing what he has learned, what he feels, what he knows. And that in this way, we can see that a patient who has been in a state of denial for a long time or in a stage of negotiation may start moving towards acceptance, which is it's an important part of the process. So these are the 10 questions that you'll find in the guide. And as I said, have all the justification, the geographic support, so that they can now be adapted to the reality of each one of your environments.
Because this was, we emphasize that the guide be totally adjusted to the reality of each of our countries. This is the presentation of the guide, and you can download it in 3 languages. It's already available in English, Spanish, and Portuguese. You can download it through this link, which is a QR, and also through a link that we can provide through the chat, or also on the WHO website generated for the World Diabetic Day, and a wonderful view of my city with the cathedral with blue light to commemorate the World Diabetes Day. A beautiful photo, and that the cathedral in your native city would be with blue light. And the experience of this guide is very important for us. So thank you very much. We have a few more minutes for a small Q&A round. So I invite participants to turn on their cameras, and those who are seeing us, feel free to send your question through the chat. We already have several questions. Most ask how to access to medications and to education. But before addressing this topic, I want to go back to Nubia, your experience in Colombia. For me, it's fantastic involving civil society in the planning and decision-making of all that has to do with diabetes. This does not guarantee success, but it enhances the chances of success. Nubia, what would you recommend to other countries? How can other countries implement similar initiatives? How can we do this? Because every new initiative breeds some discouragement. So we need to coordinate different criteria and personalities. How to address depression and then continue after the adoption of new criteria or the strategy. And what, in your opinion, has been the greatest impact in this grand table at the diabetics policy level? Well, thank you for your question. Yes, this has been an experience that has allowed us from our sector and our subdirectorate to address the challenges of new policies. We talked about all the time of social participation as a sort of mantra in the area of public policy, especially in health. But this is very demanding. In our case, we have to address our institutional strategy because social participation requires a constant dialogue and times that are not always institutional times, but the times of the providers. And we need to establish trust links that are not immediate. And those of us who are in public service, we need to have certain leadership capabilities and of a sensitive and empathetic leadership, especially when some of us have gone through very challenging life experiences such as dialysis, different treatment barriers, mourning. Now the sound. Well, mourning for having lost a relative or a friend. So we need different capabilities that have been consolidating. We need an empowered civil society. And there has been a great work in this respect. And they were those who knocked at the door and said, we want to participate in the policy. The ministry has always been open, but there was no formal way to involve the civil society. There were informal meetings and also emails, but we needed a formal space with a technical secretariat, an organized agenda, goals that we review and address jointly. And all of this has been underlying great part of the success. And this leads to the second question, how to overcome adversity, how to also address what implies the consolidation as a unit, because initially the social participation groups and tables needed different individual interests in silos. For example, a scientific organization has some specific interest. Another organization may have interest in specific education topics. And all of this, I think, it's a natural process. We all have different interests, and then we join hands. And then this is very important. So in addition to generating trust links, we need to consider ourselves as a team that works jointly and that we feel that our participation leads the policy areas. And all of this requires of tolerance. Changes are not immediate, especially now that our country is facing certain issues. So there is a transformation in our sector, which generates a lot of questions and uncertainty. But we need to work together to address these topics. The impact is especially in the legitimacy of the policy. We cannot measure exactly this, but we can see that those who participate in the grand table, and thanks to them, the rest of of civil society may recognize that it's possible to have an active participation. Thank you. Thank you very much, Nuria. I believe that your words summarize perfectly the concept of what we want to achieve, our common goal. You said something that led me to think, and we are a team. We have to integrate this idea. Diabetes is not something that we will be able to control just from the health sector. All of us have an involvement in this. In my presentation, I mentioned that there were about 62 million persons with diabetes in the Americas. But that is an underestimation. There's an underestimation of about 40%. So we are aware that at least 100 million people have this condition in the Americas. And if we think that each one of us have a relative, a close person, or a friend that has diabetes, it's not difficult to realize that there are many more millions affected by this disease. So thank you very much. Carolina, your presentation also elicited a lot of interest. And there's a question about whether there's a cost estimate. I imagine that your initiative required resources. How did you overcome the financial issues? How did you achieve sustainability over time in your initiative? Well, first of all, the project itself would have not been feasible without support from the government, the ministry, and public agencies in general, which has to do with what you say. We cannot control diabetes only from the health sector. We have to involve other scientists, engineers, the entire government, and also incubators of projects that made that initially to develop, test, and pilot the project. Thanks to all this coordination, the resource needs were not so high, but in the cost estimates have been complex because first of all, we need a platform, a software, the doctors that can be hired by the digital health department of the ministry, but it can also be hired by the health service or ophthalmic units, or could also be an eye specialist with extra time at a complex hospital. So the service is adjusted to the local conditions because different locations have their own realities. And we learned that we had to take this into account. There's also the fact that this strategy joins other strategies that want to bolster primary care. And we have an oculus fundus screening, but we have ophthalmic units that not only treat oculus fundus, but also cataracts, eye lymphomas, glaucomas, etc. So also surgical responses. In estimating costs, we also have to assess this because there are fixed costs that are shared among more strategies. So when we were about to implement this, the pandemic came and the fixed costs had to be maintained even though these different areas were not working at 100% of their capability during the pandemic. But we know that this is much more cost effective because the property, the platform has already been purchased. The algorithm belongs to the health ministry. There are limited capacities to process images. Now we can process 200,000 images per year. But in next year, we want to scale up the coverage as much as possible. And that will also have another cost, but a cost which will then be covered or absorbed in the following years, given their benefits. And the remote report costs about $5 right now, which is much cheaper than a 1 hour of in-person consultation with an eye specialist. We don't have specific figures, but we know that, of course, our initiative is cost effective and also considering the impact of blindness on the blind people who are blind and their families and the system. And this is really very important, I think, if we stop to think that there are millions of or hundreds of thousands of people who are struck by blindness, by a disease that, at least in theory, is preventable. And we have to put an end to this, really. Thanks so much, Carolina. Ana Fernanda.
The guide generated huge interest. The most frequent questions were, where can we download the guide? But you did put that in the last slide. It'll also be available on our webpage at PAHO, so you can get the link there. And then another frequent question is, how can you have access to education in diabetes? But in addition to that question, I'd like to ask, say we often talk about diabetic education done on the one hand by the medical team who's responsible for the team, and then on the other side, people who have diabetes. But what's the importance of involving all of society, the rest of society? Actually, thank you very much for those questions. I was reading the chat and I did see there was a lot of interest in talking about education, including IDF this year has set as its goal, let's educate ourselves to protect our future, precisely because education is one of the fundamental pillars of treatment. When we decided to do a diagnosis of the associations that are members of IDF in the region, we asked a series of questions to see how they educated in these spaces. And we found a controversy, which is exactly what Carmen asked, a controversy between education and activities. A lot, and it's often a lot of confusion about that. Sometimes we have a fair or we have some sort of campaign and we confuse that with education. But education about diabetes is something that has to be structured, have to have a specific program, a clear timetable. As I said, the guide tells us, it tells us what themes we have to address and the time in which we need to address them. And they also have a special characteristic. Education about diabetes is based on the life reality of the person who's living with diabetes. I can have a general program on diabetes education and have it seen from a completely rigid perspective. That does not work in education. The concepts may be universal and generic, but the manner in which you educate for it to be successful, it has to be adapted to the life of the person living with diabetes. For instance, we had a mother in the chat who said, how can I find education? I have a daughter with diabetes who's 24 years old, and I haven't seen any formal education for that. So that's precisely why it's the basis of her specific needs that we decided to create this very valuable document. It's the first time that the education has an education guide and has an adequate organization for the training of both the professionals and the patients. We have health professionals, educated people on diabetes education. Once we have that, we will have patients educated about diabetes. They'll know how to control their own diabetes. So I think this is an excellent effort that took more than 2.5 years to complete and which you now have available to you. And for us, it would be a great pleasure if you would actually implement it. Thank you very much. A very valuable resource. Unfortunately, we have to conclude. Our conversation is very interesting, but we've already gone beyond the time frame. So I'd like to thank all of those who participated, our panelists, the people who are managing the platform in the background, the support staff, and all the staff in PAHO who helped us organize this event. In conclusion, I'd like to ask Silvana to say a few words of closing. I think that would be helpful for everyone. Thank you, Carmen. I also don't want to extend this webinar, which was very interesting, but I would like to join the others in thanking you, Carmen, for having organized all of this and for presenting the panorama of the diabetes in the region, where we can see the gaps we have in the health services in our attempts to reduce prevalence and mortality from diabetes. I also would like to thank Dr. Bautista for telling us about all the progress they've made in Colombia and this concept of a multisectoral roundtable, which could serve as an example for other countries in the region, for them to set up groups to help support changes and develop health policies to support people living with diabetes. I also would like to thank Dr. Lara. The initiative done in Chile is, wow, incredible. I was telling Carmen in a chat that it's because of the organization and healthcare services that already exist in Chile that you were able to implement such an innovative strategy using this technology. And we hope that that technology can be expanded to other countries to prevent retinopathy. And Dr. Sanchez, thank you for this new guide. And I agree with you that this is a very necessary guide for all countries in the region to strengthen the education about diabetes. So it's been a pleasure to share this World Diabetes Day with all of you. Thank you once again, and thank you to all participants for having stayed with us for the whole period of time and actively participating in the chat, and the interpreters for giving us the opportunity to speak either in English or Spanish. And also thank you to the PAHO team that supported us in organizing this webinar. Thank you very much and have a great World Diabetes Day. Goodbye.
Gracias.
Goodbye. Thank you.